Good morning. This is Terry Kuti, founder and director of Deep Sea Foundation. I'd like to welcome you to the educational video channel where we talk about a number of topics that are related to breast cancer and breast reconstruction. I'm joined this morning by two very lovely women I'm happy to introduce today. And the first one is Dr. Dancey, sitting in the lovely red chair. And she is a consultant plastic surgeon trained in the UK. She's a member of the British Association of Aesthetic and Plastic Surgeons and also the British Association of Plastic Reconstructive Aesthetic Surgeons. Welcome back to the program, Dr. Dancey.
Thank you very much. It's an absolute pleasure to be here, and thank you for inviting me.
Yeah. I'm jealous of your chair. It looks so comfortable.
It is actually.
I'd also like to introduce Dr. Femke Leathes. She is a clinical psychologist providing support for patients around their surgery. She's a chartered clinical psychologist accredited by the British Psychological Society and a fully registered practitioner psychologist by the Health and Care Professions Council. Femke, welcome to the program. Did I get all that right?
Thanks, Terry. Yeah, that's perfect. And I'm very excited to be here. And thanks for inviting me.
Absolutely. The reason that I invited Femke this morning, she is on the coordinated care team with Dr. Dancey. And this is a service that is not, for our viewers, it's not automatically woven in to the coordinated care program over in the US for those who are going through any type of reconstructive surgery, whether they are having surgery for breast cancer, whether they are having reconstructive surgery as a prophylactic measure. In the US, the services are certainly available, and we have some fine services available to us. However, patients have to ask their caregivers for it. And Femke is part of Dr. Dancey's team. So I'm going to begin today, if you don't mind, Dr. Dancey. I'm going to ask you the first question and kind of walk us through how it works and tell us, how do you assess a patient when they come in to your office for reconstruction to refer them to Femke's services?
Thanks, Terry. Well, it's fairly straightforward, really. I get an idea when I see a patient as to whether I think they're going to struggle or not. But at the end of the day, I'm not a qualified psychologist. I can't tell exactly what. So for me, all my patients, anyone sort of in a complicated group or who is likely to have psychological problems, I send to Femke. And that's not just breast reconstruction. You get patients who are having a breast aug or something straightforward that's not related to breast cancer who struggle just as much. So it's for anyone that's got worries about surgery and wants to just talk it through. And also to talk to someone who's completely neutral. Sometimes we've got family, you don't want to say too much to them, you don't want to tell them exactly how you feel because you don't want to burden them. And I think Femke gives that opportunity in a completely neutral environment where you can say what you want. Femke's not going to judge you, it's between her and the patient. And then she also feeds back to me if there's anything that can help the patient. So we've had a few that are needle phobic, or they wanted to meet the scrub team and the anaesthetic team in recovery before they had their operation. You know, just simple things make a big difference to patients. And, you know, you find there's a lot of problems with patients that I'm not aware of that they don't mention, like previous abuse or post-traumatic stress syndrome. And all these things are really important, you know, and actually that's the sort of thing you get a curveball from when you operate on the patient, and it all goes really well. But in recovery, you have huge amounts of problems. And we've previously had a patient who said she wanted to commit suicide post-op. She was so distressed. And if it hadn't been for Femke, goodness knows what we would have done. But, you know, Femke calmed her down. She went home. She was absolutely fine. But it makes such a difference to the patient. And I think certainly for breast reconstruction, it's not just the surgery, it's the family side of it. And most breast reconstruction patients are mums or have children, some very young, and they feel very responsible for them. And they feel that perhaps reconstruction is a guilty pleasure. You know, they've had their surgery, and that was essential, but this bit isn't. It's their choice, and they could potentially be putting their life at risk or have delayed recoveries. And of course, women always worry about that. In my experience, men never worry about that sort of thing, but women carry a lot of it around with them.
Femke, what a process.
Yeah.
Can you describe that? Thank you so much, Dr. Dancey. I need to hear from you and how that goes for you before the surgery, after the surgery.
Yeah, sure. That it really is a process, and I think that's one of the more unique ways that Anne works, is that she embeds this support, you know, routinely in what she does, not just as a sort of tick box, right? Okay, we've had a psychologist involved who's done some kind of assessment, tick, and you know, she's in this to sort of help people, you know, and help them realize their goals and move forward with their life. And surgery is part of that. It's never the only solution to all of that. And, you know, and Anne knows that and understands that, which is why, you know, I'm involved and work together. And so that it is very much a process. And I'll, in the sort of pre-op meeting, I kind of start by just sort of reflecting, or helping the patient to reflect on their journey so far, because although in a way this is a sort of start for them, or they're at the beginnings of the reconstruction, they've been through so much, you know, already just to get to that point, and they haven't always had a chance, you know, in that sort of confidential, totally separate environment, just to sort of process that, really. So we start there, and then what we're doing is kind of looking forward, looking towards their goals, which on the one hand, as far as surgery are concerned, of course, are physical, but there are huge psychosocial goals as well, and the two things, of course, are not separate. You know, they're interwoven. So we look at both of those things, and how both of those sides have come together to help them almost make the decision, because not all of them are at that stage completely decided that they want to go forward with reconstruction. So we talk around that decision, and you know, most of the time patients through that process will come out saying, yeah, I kind of made that decision. I'm now really sure I've made that decision, because like Anne was saying, there are doubts and there's all sorts of other things that kind of creep in. And we also recognise that for some patients it may not be the right time to go forward with the reconstruction for whatever reason, and that's okay too. You know, it's a yeah, this would be a good thing, but not now. So that can sometimes be one of the outcomes of the appointment. But following that, towards the end of that appointment, we look at expectations for surgery. So what do they expect it to look like physically? What's going to be the impact of that on how they feel about themselves, their relationships, their sense of identity, and other aspects of their life. And you know, we talk that through and start for some patients to reset some of those, because sometimes we will get a patient that says, I just need to get this reconstruction done. All of this is then going to fall into place. And of course, that's a huge responsibility that falls on the reconstruction. And sometimes it's more helpful to think of it as part of you know, an answer to taking things forward, and I can support them to think about the other elements that might be helpful to focus on as well.
This is amazing to me. I'm sitting here almost going back to my own reconstructive process. I was so fortunate. I didn't have any quote unquote difficulties coming into it, some of the ones that you mentioned, Dr. Dancey, and that you talk about addressing, Femke. And I had a seamless experience and a seamless recovery. But here's something I'd like to ask either one of you to address, because I just, you know, Femke, you mentioned the word expectations. And this was just brought up in a conversation on a Facebook group that I admin, and I know, Dr. Dancey, you're part of that. You know, expectations are kind of a difficult thing to address and address from the plastic surgeon's point, but to accept from the patient's standpoint, because there are different body habitus. And you're given a canvas to work with, Dr. Dancey. And I think sometimes it's my sense anyway, when patients think of the word plastic surgery, even though it's reconstructive surgery, yes, you're nodding, you know where I'm going with this. Even though it's reconstructive surgery, they're not going to come out with this completely redone body. But Femke, you addressed the whole, you know, the expectations, the scarring, the psychological. How do you I'll let you both address this, but how do you realistically and gently tell women, this is about reconstructing your breasts. We're going to do as much as we can to achieve symmetry. Dr. Dancey, I'm going to let you touch on that because you're nodding and I think you know what I'm talking about.
It's a huge problem and a very good question. I try and address that starting when I see them in clinic. So ways that I can help is to show patients photographs. So I never put photographs on my website because there's a huge range, exactly as you say. You've got Kylie Minogue's on one hand and you've got larger patients on another, and Birmingham tends to have a lot of larger patients. And so they're never going to have a perfect breast. A breast that's reconstructed is not a replacement for their previous breast. It is different. And trying to get patients to accept that's sometimes hard because they want to be put back exactly as they were pre-surgery. And it's difficult to get that out of their head. So it's really important to emphasize they're going to have scars. It's not going to feel the same. You know, there will be differences and it won't be 100% perfect. And I always like to say to patients, even breasts before surgery are not perfect. They're not the same. They're sisters, not twins. They're never going to be identical. So it's important to get them to understand that. So when I show them photographs, I try and make them appropriate for body habitus and the type of reconstruction the patient's having. Because at the end of the day, a deep flap versus a implant reconstruction is going to look very different. So, you know, there's no hard and fast. And so we go through those photographs and I try and show a good, a bad and an ugly. So, you know, patients get a view of results. You know, I can show them my absolute best, looks perfect one, but actually that's not going to be given to everybody. You know, if they've had radiotherapy, it's not going to be as good. You know, there's huge amounts of things that impact upon it. And also, I like to get the patient to send me a photograph of what they want to look like or what they like in a magazine. So I can see what they're expecting from this. And then I can go, okay, that's not, we're never going to achieve that. And I can sort of explain that to them. But my work's only kind of, the end of the day, we've got a limited time in clinic. You know, I don't charge my patients for consultations, so they're all included. And that means that they can come back as often as they like. And I often want them to come back more, because it's a chance to think of questions, write them down, go over them. And I also say, look, do you want to bring your partner the next time, or someone with you? Because sometimes, you're never going to take all of it on board. Whereas if you've got someone else listening, they'll pick up other bits to you, and you can talk about it in the car and things. And obviously partners, they're kind of out of this a bit when they feel a bit that they're not involved. So it's really important to give them an opportunity, if the patient wants, obviously, to be involved.
Yeah.
But Femke is my main. So once I've started the process, I then got Femke to continue it, and obviously she's got better techniques to do with the psychology around it and what patients want, so that they're reassured that what they're expecting is not unrealistic. But it's a hard thing to do, and I think patients are aware of that as well. And they often say to me, I'm worried that my expectations aren't quite right. And I think they realise that. Patients aren't stupid, they know themselves, but sometimes they're not given an opportunity to talk about it. It's very much in clinic, you're like, you've got 15 minutes, on you go, you're out the door. And that's not how we want it to be. And where I can't spend all day, I know Femke can spend an hour or so with them, and post-op as well, because it's a huge roller coaster surgery. You're always down in the dumps about week 2, and wish you'd never bothered and hate the surgeon, and then by week 6 you kind of come through the other side and you go, no, I'm so glad I had it done. I wouldn't not do it. But the first couple of weeks you're like sore and not being able to mobilize as you want to, and it's always worse than you expect, isn't it? Because we always look through rose-tinted glass spectacles. Even childbirth, time's horrendous. About a week later, we're like, it's easy, I can do it again. And it's the same with surgery.
Yeah, and Femke, I've written a blog before just about touching your breast after you have any type of breast surgery, whether it's implant-based, autologous, or you're doing it, for an aesthetic reason. Walk us through how you deal with that with patients, because as I said, I had a good experience, but I think I make an analogy of a little child who gets hurt and they don't want to touch their boo-boo. Mm-hmm. How do you walk patients through embracing their new bodies and, being able to actually at some point touch their breast, and to know that their partners, it's okay. Sometimes they have to coach their partners through that.
Yeah, I think one of the hardest parts of all of it, and I think Anne alluded to this just now, is this idea that a lot of patients have about going back. I want to go back to what I had before, and that is physically in terms of their breasts, but also in so many other aspects of life. All patients have been through something horrific with cancer. There's no two ways about it, and something very traumatic. And it's quite natural to want to sort of get rid of that from your life and go back to where you were, almost like press the restart button, forget that happened, and move on. And actually, psychologically, we know that is not the most helpful way. And if that's attempted, there will be a lot of troubles and problems later. So what we're trying to do, or I'm trying to do, and as well, is change that narrative a little bit to, you have been through cancer, and make that part of your life story and process that, and come out the other side not as exactly the same person that you were before, because that's not possible now, but it isn't a negative thing either. That you're an individual with values and purpose who also happens to have experienced cancer and has needed a reconstruction, or has opted for a reconstruction, and to just change the way that's seen, which ties in very much with them knowing what to expect, but also, I suppose, accepting the reconstruction can deliver, because as Anne said, it's never going to be exactly what it was before, and it's certainly not going to be perfect. And of course that's subjective, you know, everybody's expectation and opinion of what perfect is or what ideal is different, but it isn't. And just, you know, recognizing that it's a new sort of way of being, but that they can accept that as part of themselves and as part of their life journey. So we do quite a lot of in the sessions, and often it's only the 2 sessions, so we have to, you know, sort of cram it in, but we're using narrative therapies, techniques around that, helping them to sort of construct a story for themselves that incorporates that. We use elements of acceptance and commitment therapy, or ACT, which you know, hopefully maybe some people will have come across, all of which can help to kind of reset that. And then when, you know, we're sort of meeting post-op, we're reflecting back on some of that, adding in a little bit more, talking about, you know, what's it like now that you've you know, had the reconstruction. Tell me how that's going in terms of how you feel about yourself, the clothes that you're wearing, what's that like, you know, in your intimate life. Talk to me about kind of what's going on there, and patients will be different, but it's about helping them kind of embrace that, knowing what to say to partners who might be, as you said, a bit kind of wary. So yeah, I mean, it varies depending on the patient, but that's the kind of approach, I guess, we're trying to use.
You know what? I have to tell you both, this has been such a valuable conversation. I think at some point we probably should, you know, revisit this. The 2 words that I took out of this that I heard both of you saying frequently were the words goals and expectations, and realistic goals and realistic expectations for patients. This is not an easy journey that women go through. So the assistance that both of you are providing in a coordinated care team effort, to me, is phenomenal. I really appreciate you being on the program today, and I look forward to continuing this chat soon at some point. Thank you both for being here today.
Thank you so much for having us. It's been lovely talking to you, and hopefully at least it's something for patients to think about, particularly if it's not available in America. You know, it's something to push for, because it makes a huge difference.
Yeah. Femke, thank you so much.
Thank you, and I completely second what Anne said, and I guess my message to any patients listening who haven't already been offered this support is, hopefully, if you can ask for it, and there is a way of getting it. I know I would say that, but I firmly do believe it will benefit everybody.
I do too. Please comment or let us know, comment on this particular video, but also let us know if there's any other topics that we can cover. We'd love to help you out. And thank you again to these 2 lovely women over in the UK for having this discussion this morning. Thank you.